Good evening, everybody. Thank you all for spending the evening with us. My name is Elena Frid. I'm the Alumni Association President. The Alumni Association is thrilled to bring this lecture series to you. We're planning to make this an annual event and hope you will join us for future experiences as well. I would like to take this opportunity to ask you to join us and get involved with the Robert Wood Johnson Alumni Association to reconnect with your classmates, give back to the school, and most importantly, impact the lives of students. Please reach out to Gillian Pryor, our Assistant Director of Alumni Affairs, for more information. And now, Dr. Leo Iliadis, who is our Alumni Association event chair and put this event together, will introduce the panelists. Leo, take it away.
Thank you, Elena. My name is Elias Iliadis, and I'm a member of the Robert Wood Johnson Rutgers Alumni Board and Chair of Programs. I will act as Master of Ceremonies for tonight's event. Welcome, one and all. I would like to thank everyone in the medical community for joining our first annual and first virtual Alumni Association event. As Elena said, the Alumni Board believed that an event highlighting our alumni and their expertise was important and allows us to come together as an association and community. I would like to offer a thanks to the Rutgers University Alumni Association who helped put this Zoom logistics together. Thank you, Lauren. Wouldn't have been able to do it ourselves. The Rutgers Robert Wood Johnson Medical School Alumni Board would also like to give our heartfelt thanks to Gillian Pryor. She coordinates events like this and our meetings throughout the year. So many thanks, Gillian, please. Tonight, we have an amazing group of panelists who will be discussing how healthcare delivery has been changed through the COVID-19 epidemic. Our presenters include a physician and member of state government, 2 CEOs from health systems across the state, a dean of medical school focusing on diversity, a chief of medical staff at a major teaching hospital, and a dean of Rutgers Robert Wood Johnson Medical School, all offering their expertise and experience. We hope the presentations and, more importantly, the question and answer session will be the highlight of the evening. Here are some program details. Each panelist will present their perspective of healthcare access to the COVID-19 pandemic and how it affected their specific field. After all 6 panelists have presented their perspective, we will begin a question and answer session. Questions will be submitted through online chat function only and will be sent and can be sent at any time. If you wish to address a question to a specific panelist, please list their name in the question. Otherwise, we will address it to the entire panel. I am looking forward to an enlightening and informative event, and I'm happy to introduce our first speaker. Dr. Herbert Conaway is our New Jersey State Assembly person, a member of the Health and Senior Services Committee as its chairman, is a physician and also a lawyer, has been a friend to the Alumni Association, and I welcome him this evening. Herb.
Good evening, everyone, and very delighted to spend some time with you discussing healthcare policy and the direction of healthcare in our state. Healthcare certainly has taken a front seat position, as it should, in a time of a pandemic, and many people have, I'm sure, spent a lot more time thinking about not only their own healthcare, but the health of the nation. And so this discussion is timely and important, and I look forward to the presentations and the questions that will follow the presentation. I've been asked to discuss New Jersey's response to the coronavirus pandemic, and as you no doubt have observed, it's a national and state responses to the pandemic have been first and foremost. One of the earliest actions that the government took under the under the Murphy administration, similar actions I'm sure taken right straight across the country, was to enact emergency measures in response to the pandemic. The governor and the commissioner of health actually have enormous powers that they can bring to bear to help move the institutions of government to stand down and face off against a pandemic. People actually don't know your local health board has a tremendous amount of latent power to quarantine and to take all sorts of direct actions. A lot of latent power. It's not often used, but now you take that power which exists locally and expand that statewide, and you understand the enormity of the power that that can be brought to bear and needed to be brought to bear to face down this pandemic. It's not a long walk down memory lane to recognize it was only 6 months ago, or to recall rather, it was only 6 to 8 months ago that we had hospitals that were overrun with people entering the hospital with very severe illness. A number of people unfortunately did not make it because we did not have the treatment protocols made yet. This was, as a new virus, you really didn't know how to manage it. And so you found the government needing to marshal the resources that were available, managing and controlling access to ventilator beds, managing and controlling access to hospitals, managing and controlling access to nursing homes for those people in the earliest stages who could actually make it to a nursing home, marshaling and the resources which we found and discovered are far too little in terms of personal protective equipment, controlling access to them and distributing them to those areas that were most hard pressed by the virus was certainly one of the important roles of government. The other large set of things were done was to get professionals in New Jersey to lend a hand in treating the many people who were hitting the medical system with viral illness. Now, that meant relaxing the standards, the licensing process to allow out-of-state professionals to come in, nurses, doctors, to come in and treat people here in New Jersey. We took action to relieve hospitals, doctors, and other people involved in the healthcare system from liabilities that might spring from that. Now, that was controversial, but there was, many of you may remember that in the wake of the hurricanes that hit the Gulf Coast, there was a case where a nurse and physician had to evacuate patients to a roof. Power was lost. They were handbagging a patient for darn near 24 hours. That patient unfortunately expired. But even in those circumstances, the health professionals were sued for malpractice. And the concern was with the lack of PPE and the threat to medical staff, that the further threat that might loom as a result of medical malpractice actions would actually leave us bereft of the health care professionals we needed. And so we took action to prohibit liability in those spaces so that we would not have that as a barrier to our own professionals risking their lives, and actually they were risking their lives to go in the hospital and work, and as a barrier to those we would need to come to New Jersey from other states. And so that was among the important early actions that were taken as well. We had to deal with the emergency medical transport system and how we were going to deal with police, first responders, protections for the actions that they needed to take, because it is that ambulance employee, that it's that police officer that often has to get in to a home, get to the scene to get someone scooped up and into the hospital, but they didn't always have the PPE that they needed. And in healthcare, as you know, we have to protect privacy. So there was a tension, I will tell you. We dealt with this for a couple of weeks to try to figure out how we give information to emergency services to let them know where there might be risk to them in entering a home, while still trying to protect the legitimate privacy rights of citizens and their healthcare. And so there was quite a lot of back and forth trying to figure out just where we could strike the appropriate balance between the need for first responders to know and the need for individuals to be protected in their legitimate privacy interests related to their healthcare. Quite a lot of time was spent dealing with that. So a number of changes in the area of first response, personal protective equipment, marshaling resources. We depended, as we should expect to depend, on the federal government to send resources to New Jersey. We were in receipt of shipments of PPE. We were in receipt of shipments of ventilators. We eventually received money to build stand-up hospitals and other healthcare venues across the state. All of this required executive orders and a command and control, and certainly the stay-at-home orders were among the, I would say, the most important and life-saving things that were done. Controversial again, because it required people to stay home. That shut down the economy. But without those very strong measures, the deaths that we saw would have been worse. And this, of course, is something that's been argued back and forth right straight across the country. It's one of the controversies that impacts the current election, is just when should governments act to restrict freedom in order to protect the spread of pandemic. If you look back at whether it's the Spanish flu, if you look back at cholera that hit Europe and the British Isles, hundreds of years ago, there was always this tension that government leaders have between deciding when to take action to initiate quarantine procedures, to close down borders in order to protect the body public, and being concerned about the economic impact to that same body public. And unfortunately, almost every time, government leaders got it wrong. They waited too late. And as a consequence, far too many people, more people died or got seriously ill than would have, but for the timely application of government power to impose stay-at-home orders, to impose quarantine orders, and to basically protect people from themselves.
Closing thoughts, sir. Closing thoughts.
I've been asked to talk about some of the changes that, and I'll just mention, telehealth is probably everybody on this line as physicians has been involved with telehealth. We've had to make some changes to ease that process. We had actually had a telehealth bill done a couple of years ago, and we're looking at some reforms of that. And I think what we're seeing and understanding is that people are very receptive to telehealth. I certainly have a concern about the practice of medicine and how it is performed in that setting. But so far, I think most of the people with whom I've interacted have been very pleased with that. And many of the physicians have been pleased to be able to continue to deliver care even under these very difficult circumstances. Going forward, we're going to have to debrief this situation and understand what changes we're going to have to make to prepare for a recurrence of an event just like this. Far too many of our important resources were offshore and far too in short supply, given the just-in-time nature of a lot of the inventories that the healthcare system has, not only the healthcare system, but straight across the economic system. We're going to have to rethink the sourcing of critical supplies and make sure that they're available to us when they're needed. Nursing home reform, somebody will ask about that, so I'll stop there, but pleased to join you and look forward to the other presentations.
Thank you so much, Dr. Conaway. Excellent presentation. I look forward to some great questions. Our next speaker is Dr. Anthony Mazzarelli. He is an attending emergency department physician. He's the co-CEO of Cooper Health System. And I welcome you, Anthony, this evening. Anthony.
Thank you. It's a pleasure to be here. I don't trust myself on the timing, so I'm going to set my timer here so I can hold to the timer on this. So in looking at the question of the future of healthcare through what we've learned through COVID, I sort of think about it in three buckets. There's pre-COVID, peri-COVID, post-COVID. So all the things that we thought about and were concerned about pre-COVID still hold true. So there's still things we have to think about in the era of post-COVID. So things like access demands that patients have, burnout with providers, whether it's physicians or nurses or APPs, the intensifying margin pressure in healthcare because revenue isn't going up, it's going down, but expenses are going up. the deficits in compassion, that people aren't able to connect with patients the way they want to, the market disruptors out there. So all of those pre-COVID pressures, those are still there. And then of course, peri-COVID, what's happening now, we're still really in it, even though we had that, that big rush in the beginning in our area. And then so in the middle of this, of course, the big rush in the beginning was safety. Safety, safety, safety. It's still a big, important and number one thing for us to think about. So, you know, spending $6 on an item that costs us 32 cents is the norm. Something that none of us, I think, thought twice about doing. But even more beyond going past PPE, the big thing that became, I think, the number one thing next to what you had to buy for safety was communication. And so changing the way we communicate, which will change us in the post-COVID era, which is communication became the pathway to safety. Because really there's only a kind of a fine line difference between whether you have people in your health system you're communicating to, really a fine line between whether what they hear, they think is a mixed message, or what they hear is they feel informed. And whether you're communicating a lot, that fine line has to do with how well you're communicating. So we really took a sort of a 5-prong approach we had to think about every day. Were people feeling, they want to feel heard. So are they feeling that they're being listened to? Are you listening back? Are you really taking the frontline experience and understanding and addressing concerns? Do they feel protected? Are you reducing the risk of people who are getting infected and transmitting that infection to their loved ones? Do they feel prepared? Are you providing training and knowledge about what is the ever-changing knowledge base about this disease, which the only thing spreading faster than disease was knowledge or misinformation about this disease? And then do they feel supported? Are you making people feel supported about what the human limitations are of this because of the extreme hours people are working, or the uncertainty, or people having to practice out of their normal scope? And last is, do people feel cared for? And are you thinking about things outside of just, are they working hard, but are you providing employee assistance or resilience training or those kinds of things? So those 5 elements became part of communication, something that we didn't think about regularly during the height of COVID, which is really, we're still during that time. So safety and communication as part of safety. And then another aspect of this, at least from what I do, was about co-operators, competitors that really became partners in this, that you cooperated with, that we worked together. So all the health systems in South Jersey, and this happened in all the different parts of the state, we really came together and thought, how can we protect patients? How can we protect our staff? And that really became something. And the very bottom of the list, in fact, not even really thought about, was about volume and financial hardship. That wasn't something that became a factor. We were really thinking about those top issues. And then of course, is the sort of post-COVID world. And in the post-COVID, which we're now thinking about, even though I still put us in that peri-COVID period, is how do you make yourself sustainable? And a lot of the things that we did peri-COVID with technology and some of the things that I'll mention now, those are things that were on the roadmap that we figured out we actually can do. So when you think about, Kate Walsh is the president and CEO of Boston Medical Center. I think she puts it well. She talked about the 4 R's: responding, rebounding, rebuilding, and reimagining. So responding is what we are doing and still doing. So that's doing telehealth, which everyone we were able to turn around very quickly, and all health systems did. Even doing telehealth within the hospital. Can you actually see patients within the hospital? We did some of this in order to preserve PPE within your staff. So you're still seeing patients every day, but can you respond to them in different ways and keep them informed? Can you keep them connected to their loved ones in a way, and using technology in the hospital, putting technology into place that can help us, that is on the roadmap, and then figuring out, hey, we can put things into place and do projects way faster than we ever knew before. Then of course, rebounding is thinking about the illness burden that has built up because people aren't seeking care. Think of all the thousands of screenings and things like that that aren't happening because people aren't seeking out care. So the number of people whose cancer is progressing or aren't getting diseases diagnosed. And so we have to think about that. And then rebuilding is, how can we bring back care back, but what's really important to bring back maybe to our campus. So this is the number of workers that maybe can work remotely, or rebuilding in such a way that, mainly for non-clinicians, maybe not replicating things from before that we don't need. And then lastly, reimagining how we do care. So that's the last phase, which is everyone knows the healthcare system has significant challenges. So what's a better way to care for patients and a better way to do things? So I think the communication is going to be better than it was before. Telehealth is here to stay in certain forms. And knowing that we can change faster, that we're not this big bulky thing, that we can respond and change faster, and we have to be prepared for these kinds of things in the future. So I think those are the kind of things we have to think about. And we've kind of shown that we can work together, that we can change, and that we can provide better care even in these circumstances. So now as we face maybe a potential another wave, can we do what we did before and still not cancel elective surgeries and still see patients? Can we still convince patients that they can come and it can be safe for them to come, go to their doctor, go to a hospital, and even if we have another surge of COVID being here? So those are sort of my thoughts, and I yield my final 12 seconds back to you, Dr. Iliadis, to whoever's next.
Dr. Mazzarelli, thank you for informative discussion. I appreciate that, especially as someone within the organization. It's wonderful to hear your thoughts. In alphabetical order, our next speaker is Dr. Jocelyn Mitchell-Williams. She's RWJ class of 97. She's a practicing OB-GYN physician, associate professor of obstetrics and gynecology at Hoover Medical School. She is currently the Associate Dean, Diversity, Community Affairs, and again, posing the same question to her: how do we manage diversity in healthcare access during COVID? So, Jocelyn, thank you.
Thank you, Leo, and it's delightful to be here to join some of my old colleagues and some of my current colleagues and some new friends. And certainly COVID has changed a lot of things, from the health perspective side and also from the medical school side, where I do deal with diversity and community affairs, which plays a huge role at our school. We're a very mission-based organization, and part of our curriculum includes our students really out there in the community and serving the community in ways that can help them overcome some of the social determinants of health. And what we saw during COVID was that this really hit the populations or people of color significantly. And many of this was due to perhaps the nature of the higher incidences of pre-existing comorbidities like diabetes, hypertension, some of those things that affect minority communities more. And we saw that they were really affected more and had higher rates of COVID infection, but also for the Black community had higher death rates. And that raised a lot of fear in those communities, especially in a city like Camden, where 95% of our population is African-American, Latino populations. And so for us, when COVID hit, that shut down our students being in not only the educational environment, but also in those service activities where they were really partnering with the organizations in the Camden community to help serve both as healthcare providers in terms of being health coaches for individuals, especially like in our prenatal practice, where we had students that were matched up with patients to help them navigate their healthcare. That sort of came to a halt. And when, as Maz talks about, yes, we had telehealth, but for many individuals in our community, yes, they might have a telephone, but they didn't necessarily have the same kind of telehealth systems where we would talk by computer, where we can actually see how people look and, kind of give an assessment in that regard. For our pregnant patients, it's kind of hard to take care of pregnant patients when by telephone or even, by seeing them on a computer. So that raised a lot of challenges for us in that regard as well. And it raised a lot of anxiety in our patients. So even those that we did want to see to come to the clinic to see us, they were reluctant to do so because they would have to get on a bus perhaps to do that, and that would increase their risk of COVID. we lost our ability to sort of be able to communicate with people in a way that we did, providing education to a population that often needs that extra guidance to help them navigate things. These are, some of the things that I worry about, as Maz again talks about, in this peri-COVID period and afterwards, is that we need to be able to think about how this is going to affect this population moving forward. When vaccines become available, and how do we, equitably distribute vaccines to individuals who need them, who are also frontline workers. Maybe they're not necessarily physicians, but they are individuals who work in the grocery stores, who are, required essential personnel, or individuals who, drove buses and were, required to work. Those are individuals that are, again, more likely to be exposed again, have higher risk for getting the virus, needing the vaccine, but having to also deal with the historical perspective that they're less trusting of the healthcare environment. And so I think those are some things that we need to think about moving forward. How do we make sure that we're caring for these underserved communities that really rely on us? And with that, I'm just going to stop there and then see if there's questions afterwards.
Jocelyn, thank you. A lot of food for thought, a lot of unanswered questions. We look forward to working through those challenges as a medical community. So exciting, interesting times. Interesting.
Yeah, we're going to need a lot of help.
Yes, we are. Yes, we are. Our next presenter and panelist is Dr. Cat Sable. He is the regional president of Southern Market Hackensack Meridian Health at Jersey Shore Medical Center, I believe. Robert Wood Johnson Medical School class of 1999. So Ken, thank you again for the participation, and looking forward to hear your perspective on healthcare delivery. Thank you.
Well, thank you, and really appreciate being invited to be part of this. I just want to say to start that I should never have given my notes on this to Dr. Mazzarelli, because he really stole everything I was about to say. So with that said, I'll do a little improvisation. I think that to expand a little bit on what Dr. Mazzarelli said, I think we're still in the the peri-COVID period, and my concern is we will be for quite some time. We are talking about phase 2, wave 2, but I don't think we really got out of wave 1. We are still in the neck of it, in the thick of it. We are starting to see surges again in Monmouth and Ocean County, where I oversee 4 acute care hospitals. And not to be unexpected, but as we start to open up indoor dining, as the weather gets colder, we absolutely cannot let our guard down. Doing so will result in exactly what I'm talking about. Just a few weeks ago, I had 0 patients at Jersey Shore University Medical Center. As of today, I have 34 positive in just a matter of 3 weeks. So it's very real. It's still here. And my big concern is, without a vaccine, herd immunity, or a viable therapeutic, this could go on for quite some time. Even if we do have a vaccine, I don't know how many of you listening would be the first to get the vaccine. I don't think I would, and it's just my own opinion that, this is potentially being rushed, and, I don't know if they've taken the time to fully study the side effects and the ramifications like they would in a less rushed vaccine development period. And so, we see what we deal with the flu vaccine and getting people to take it. This is going to be that much harder. So even if a flu vaccine comes out, short of making it mandatory, I would expect 20, 30%, max of people who will actually sign up and get the vaccine. So we could be in for this for a long haul. And, my concern on the industry is, we haven't seen margins like this in healthcare in 20 plus years, since the Balanced Budget Act of 1997, which reduced payments to hospitals. We are seeing 60% of hospitals in New Jersey are in the red. The average margin right now is -4%. The industry has lost multi-billions through a combination of lost revenue and increased expenses. And again, if we get into a situation where we get anything more than a little bit of a bump and have to kind of close down again, this will be catastrophic. Many of us in our hospitals benefited from CARES Act and other federal funding. Even with that, we're still struggling to break even. So, I think that we're not out of the woods yet by any stretch. We have to keep our vigilance up and keep our antennas up and make sure we are, following protocols and making sure people around us are as well. I also want to talk about, what this exposed for the country. And, one of the things, and I'm an engineer by training in computer science, and I like to study how systems work. But when you look around and you see, toilet paper and paper towels and things that you just can't get, and everyone's wondering what is going on. And, I read some articles about how we as an industry we as a country have moved to just-in-time manufacturing, which is, when you need things, we manufacture it at the time, and we're not stockpiling, weeks or months of supplies of anything anymore. And as a result, when something like this happens and the supply chain is interrupted and or the demand exceeds the supply by a significant amount, we don't have the capacity as a country to ramp up. And in order to build the machinery to be able to ramp up and build the capacity to develop and manufacture, the level of paper towels or PPE in our case, could take several years to build the machinery and build that supply chain. So, it's really a wake-up call. And I think that as an industry, we did everything we could, and I speak for my colleagues who are in the hospital world and medical field as well. We did everything we could to protect our team members and our patients. We scoured the globe for personal protective equipment. We paid, a king's ransom, 15 times the going rate for, N95 masks, to do anything we could to get them. And we were all doing the same thing. And unfortunately, we had to resort to emergency protocols and procedures that required reusing supplies. And we know that was a big bone of contention among our team members and others. But it's certainly not for a lack of trying, and none of us would have made that decision if we weren't under extreme circumstances and conditions. Lastly, I just wanted to talk about, to me, what are some positives, and maybe there's some silver lining to COVID in some of this. The first one that Dr. Mazzarelli already talked about was teamwork. It's amazing when a tragedy or global emergency occurs, and you can get otherwise fierce competitors together to work together to solve a common problem. We did that through each other, through being colleagues. We did that through the New Jersey Hospital Association, of which I'm a board member. And I was really proud to work side by side with all of my colleagues to bounce ideas off of each other, figure out how we could help each other. Maz and I would talk, I call him Maz, we would talk and I'd say, here's what's going on up here, get ready, in about 2 or 3 weeks, you're gonna start seeing some of that down there. So that was a wonderful exhibit in collegiality and friendship. The other one is family time. It was a strange thing that, I'm 47 years old, and probably for the first time since I can remember, certainly since medical school, everything stopped. Everything stopped. I have a 9-year-old and an 11-year-old, and, sports activities stopped. Dance for my daughter stopped. We had movie night. Despite being at the hospital 7 days a week for 2.5 months, there was something really, it was almost like, the powers that be were telling us to unplug from the machines for a little bit and reset and refocus on perhaps what's really important. And that's I think a message for all of us that, we work hard, we play hard, but at the end of the day, we're only here for a limited amount of time. And I think it's so important to be able to, smell the forest, see the forest through the trees, smell the roses, whatever analogy you want. So that was helpful. And then last but not least, also touched upon is telehealth. As a technologist myself, I predicted that, telehealth would one day, due to the healthcare industry, at least, physician offices, to similar to what Amazon did to the retail market of the Amazons in circuit cities and, what Amazon did to the Best Buys in circuit cities and retail brick and mortar. And I think we're starting to see some of the effects of that. Between the wearable technology, my Fitbit, your iPhones, that track your steps, and the Apple iWatch that can track your heart rhythm. Scales that you can you weigh yourself and it gets transmitted directly into the EHR. When you think about ways we can actually help our patients, you think about the CHF, 80-year-old CHF patient whose children have to take a day off of work, get the parent in the car, they're short of breath walking to the car, just to go into the office to be examined, get their weight checked. There's technology now that can check to see if patients are taking their medications through Wi-Fi technology. So I think that this is here to stay. For people like me who are early adopters, I choose who cuts my hair by whether I can make an appointment online. I only order Dunkin' Donuts through the app. And I think this is a wonderful way for us to move forward. I do agree with Dr. Conway that, there's nothing that replaces that personal touch, but, integrating telehealth with the personal component, I think is going to really improve the patient experience and help us to get through this and get to a whole new level. So thank you for your time and happy to take any questions as well.
Ken, thank you once again for all participants and panelists. We're going to take all the questions at the end, give more of a lively conversation. So Ken, thank you for your insights. Remarkably similar experiences, it sounds like, but it's wonderful to hear it. Our next speaker is Dr. James Salwitz, RWJ MS class 1981. He's the current president of the medical staff at the Robert Wood Johnson Rutgers University Hospital, I think, and clinical professor at Robert Wood Johnson Medical School. So Dr. Salwitz, thank you for your time and welcome.
Thank you, Dr. Liadis. Perhaps one of the nicest things that comes out of COVID, if you will, are events like this. I mean, come together, we talk, we share, we should do more communication in the future. So maybe this is a positive statement for things we're building forward. So Robert Johnson University Hospital had a lot of the same challenges that have been discussed this evening. And we had a couple other opportunities which may complement that. We're an academic medical center. The academic lead for at RWJ Barnabas System, and we realized from the start that research was going to be an important part of what we were doing through this event. But that is different in a pandemic environment. There's several problems we immediately had to deal with. First of all was the manpower issue. Everybody wanted to rush to the bedside, if you will, and then we had a need for people at the bedside as hundreds of patients started to arrive. But if we were going to do research, we were going to have to protect certain individuals so they'd have that time to do research. And we made deliberate decisions of how we distributed people, how they were supported, who maybe people from one department support another department, so that researchers could build academics. And we learned a lot when doing that. And that kind of triage, if you will, is something we'll continue to do going forward. Another was time. And any of you that work in an academic institution knows that the speed is not one of our strengths. It can take years to develop a research study, get it designed, get it approved, et cetera. And we realized that if we're really going to study this, respond to it, develop therapies, that we're going to have to respond literally in days. And so we had to make deliberate decisions on how to streamline our systems, and we looked at them deliberately. And a good example of that was the Institutional Review Board process. Those of you who have done human subject trials before know that if you're going to be doing trials on human beings, that it has to go before an IRB for the ethics and safety. And those of you who've ever dealt with an IRB know that can be a long process. And we wanted to get through IRBs, again, in days. So we looked at how IRBs are structured, how they're getting information, how they're making decisions. And we were able to restructure and learn a lot from that. So we literally got IRB approval in days. And even going back, when we look at the ethics, how decisions are made, they were very solid. And we've relearned a lot about those processes. And hopefully we're a more efficient, smoother academic institution, because of that. And then there were the ethics of doing research in the middle of a pandemic, as we were making trade-offs. And they're very challenging. One of the most interesting ones I thought was early on was in the first days. And before we even had our first patient arrive, we knew it was coming. We decided we wanted to do a survey of our clinical staff, physicians, nurses, respiratory therapists, and a number of other individuals. We wanted to study 800 individuals with viral swabs and serology. We didn't have a blood test yet, but we were drawing the blood. to see what was the endemic infection rate, and then to monitor them on a regular basis going forward. The problem with that is on March 1st, we knew there were a number of individuals out there that were infected with symptomless, but we just didn't know how many. So there was the real risk if we suddenly studied a lot of our ER people and our intensive care people that we would find, say, 25% were already infected, and we'd lose them from the front line. Even though they felt well, they were using proper PPE, they were saving lives, we could lose them. So we had to make a very tough decision, and it was a combination of medical school and administration coming together to say, what are we? What do we stand for? What is our role? And we made the tough decision, and it was a scary decision at those days, early March, to go ahead with that study, despite the risk. And we pulled off that testing of 800 people within 10 days, the first days of March. Fortunately, only 1.5% of them were endemically infected, and it did not undermine us. But these are the kind of decisions we had to make just to get research going. Through COVID, we developed a number of testing. At one point, I think we had 5 testing platforms running. We were doing most of the testing for the system, which again helped us learn a lot of our role in supporting a large system, which, as many of you know, is new to us. And we're just becoming systemness. And so we learned a lot about working together. At one point, we actually sent to another hospital an entire lab with equipment and people, to support, that effort, et cetera. And that expanded. And through the course of COVID, over 100 articles, essays, studies are running. We're still running all of that. It's so important. We are, by the way, a center for the Johnson & Johnson vaccine trial. And Ken, I appreciate your reticence, but I've already signed up for the vaccine. So, when they get it out, I will be volunteering. So, for that. Dr. Mazzarelli brought up the importance of communication. We have a large medical staff, over 2,000 clinicians. And suddenly they couldn't talk, couldn't communicate, they couldn't meet. And we said to ourselves, we've got to keep these people connected. And what we did, which we thought was unique, is we developed a daily video update, a newscast, if you will. They went out every day for 3 months. And it said, this is what's happening in the state, this is what's happening in the hospital, this is what's happening as far as changes and recommendations and structure, et cetera. And also that would be about 10, 12 minutes. And then also would include an interview, maybe with a hospital administrator or with a patient advocate or someone in the community or EMS. And those daily videos became a large part of our culture. Every single one of them ended with the words, work the problem. And a lot of people found a lot of calming and support. Simultaneously, because we have a large private practice groups that were threatened, we had a video that went out 2 to 3 times a week about how do you survive in the private practice in the environment? How do you apply for funding, and how do you do staff, et cetera? We had that going on at the same time. So those communication things were, I think, very important to our staff and kind of held them together. We also are looking forward, as we spin out now to the potential of another surge that we're starting to see. Hopefully we have now deliberately restructured our hospitals. So our thinking is, as Dr. Mazzarelli was saying, is that we will run basically 2 hospitals. One, continue to do open hearts, continue to do bone marrow transplant, continue to do a tertiary quaternary care and primary medicine, but another, a entirely separate COVID hospital. And whether or not COVID really comes back in a major way, we've learned a lot about that concept of maintaining medical care and critical care going forward. Dr. Williams mentioned something that I think is incredibly important. And if anywhere that we failed, it was in this. Our hospital, our system, as all of you, believes that we will not have succeeded until our communities are more healthy. And we saw that communities under pressure, communities of diversity, got hit particularly hard during this. And in a real sense, we failed them. And I think if there's a wake-up call to us, is we've got to realize that we've got to be out in our communities, we've got to be building more healthy platforms. So the next event, whatever that is, they are more ready, and that calls us going forward. So again, thank you so much, for doing this morning. It's really important. And unless I forget, don't forget to vote.
Thank you, Dr. Salwitz, for a wonderful summary and for a public service message about voting. So of course, that's important. Our last speaker, but not least, to many of us on this evening, Dr. Carol Terragino, Rutgers Medical School Class 1986, Senior Associate Dean for Education and Academic Affairs, has been a staple at Rutgers Robert Johnson for many years. And again, posing the question of the changes in medical education from the COVID pandemic. Carol, thank you for coming out.
Thank you, Leo. Good evening, everyone. Jim, except for you, everyone on this evening's panel has been a former student, a resident. Herb, I don't know if you remember me when I was an attending and you were in the ER, or a direct report of mine. So I guess that makes me the second oldest. I've learned from all of you tonight, and so thank you for your words. Professional activities across the healthcare spectrum have been impacted by COVID, and no less so for me, the Chief Academic Officer. And perhaps I was caught more flat-footed than most of you without the off-the-shelf contingency plans in place like hospitals have for power loss, hurricanes, the workplace shooter. My charge was and is to maintain the physician pipeline while keeping everyone, students, faculty, and staff physically and mentally well, and ensuring that the needs of their future patients, of these very students, will be met. I've been buoyed by the resilience of the education faculty and staff, for they too are heroes, immediately pivoting to provide alternate experiences, all doing this out of their comfort zones. And even the non-clinicians would always be saying at every juncture, how can I help? And through this, we've not even dropped our planned rollout of a new curriculum for the entering class of 21-22. So I just have to say to anybody who may be listening, who's out in the audience, my team is truly amazing. Pre-clerkship education is now virtual. Only critical in-school clinical activities will be conducted in person this year, and not until next semester. Our students are learning the telemedicine ropes, working with standardized patients over Zoom. They're interacting with their first patients, their cadavers, in person in a socially distanced fashion. However, rather than spending the hours at the table dissecting, they're examining prosected cadavers. And our pre-clerkship students are still trying to meet the needs of the community partners virtually, and to continue to identify and fulfill their unmet needs. So you may be wondering what it's like to teach a large group virtually. The first class session this year was my talk. It was on the art of communicating with empathy and clarity. And I'll admit it took a little bit of creativity to teach medical improv on Zoom, but I must say in my small group where we practiced the skills from the lecture, there was real participation. I felt the students' engagement. It's actually kind of hard to hide as a student in a small group class on Zoom that's set up in a Brady Bunch mode, so we're actually getting great engagement. To round out the pre-clerkship experience, I have to mention this. Take the biggest second-year stressor, step one, and then make it even more stressful with multiple cancellations. I have to say the MBME was another organization that was caught rather flat-footed in this crisis. We pulled our clerkship students in March, and since most M4 students had fulfilled the majority of their graduation requirements, the curriculum committee was able to approve small modifications, how many IV placements, how many Foley catheter placements, and we were able to graduate these students, albeit it was done virtually. And I have to say to all the alumni, we do promise to hood them in person at the first juncture that we can. We saw such amazing creativity, such as in our transition to residency boot camps with virtual simulations. We had faculty acting like avatars over Zoom, carrying out the orders that our students gave while they were dealing with emergent situations. And all of our clerkship directors very, very quickly created 2-week virtual didactics and case conferences so that no education time was lost. But what about the clinical needs of the next set of students entering the graduation year? With our Robert Wood Johnson partnership, a hospital partnership, I was able to pilot and bring back 40 clerks back in the wards in May. And I believe we were one of the earliest post-reimmersion schools that did this post-surge. The hospital really trusted me, and I'm very grateful for that. And I'll share with you my organizing principles as I approach them, that the impact on patient care and stressors on providers that providers and the health system, such as PPE, supervision time, the need for antigen testing, that had to be first and foremost before we immersed our learners back. And I needed to make sure that I prioritized which year, which learner needed which experience in order to fulfill those graduation requirements. So we've been phasing in our learners to clinical experiences. I then had to deal with 145 rising fourth-year medical students that still had to complete third-year experiences. And our non-Robert Wood Johnson sites were not and are still not presently up to speed with rotations sizes. And so I'm going to say this to everyone, and it's going to be scary. I honestly don't think that schools will be completely caught up with this until academic year 22-23. I told you my mission was to keep the pipeline of new graduates flowing. So some of our strategies, we shortened our clerkships. So to all you guys that practice medicine, can you imagine doing internal medicine in 4 weeks now? We've decoupled those standardized clerkship tests from the clinical experience, so those 4 weeks could be truly devoted to clinical competency. And remember how we always worried about grades? We wanted to get honors. Well, guess what? Now there's no honors. It's COVID pass, COVID fail. We did add flexibility to by allowing postponement of third-year clerkships to later in the fourth year, so that we could support our students needing to take rotations that would get them help them in their residency applications. And oh, by the way, there's no away electives anymore, and all interviewing for residency applications will be done virtually. So things have really changed dramatically. So I leave you with a provocative thought. We have been comfortable as medical educators, most schools, 4 years, time fixed courses and clerkships, tried and true, or is it? Given our need to decide what are the most critical competencies for our graduates to master and our need to now shorten experiences, should we also be asking, would time variable, competency-based education be a better option? Should this crisis really be an opportunity? I'm personally using this opportunity to expand my skill set as a lead for crisis management and communication for educational matters. And we're developing those off-the-shelf contingency plans for resurgence, no vaccine implementation, loss of clinical sites, disruptive internet outages, maybe even the results of an election. Maybe we need a crisis plan for that. This is just another day for a chief academic officer, and waiting in the wings, a whole new set of challenges for residency program directors who will have some very differently trained interns. Hopefully I've stimulated some thought, and I'd be happy to take questions. Thank you.
Dr. Cardina, a wonderful talk. Thank you for that. All right, we have some outstanding questions. First of all, thank you for the great presentations. My head's full. It was I have a whole host of questions myself, but trying to be respectful of time, I'm going to go through some of the questions that were presented, to whom they were presented, and some that I feel we can answer this evening. To Dr. Conaway, the question comes, do you feel this pandemic should have been managed by military protocols and physicians rather than civilian protocols and physicians and organizations?
Military protocol. Well, you know, I'm not sure there are enough trained military people that could be deployed to states, particularly at the pointy end of this pandemic. We did have contingents of military folks come in to help us here in New Jersey. But remember, there is an ongoing military presence across the world and a need to defend the fighting capability of our military. I've been serving in the military. I can tell you that at times when we had a flu pandemic that was a difficult rage across the country, you know, the base locked down. Folks at the military contingent, our focus was internally to protect the fighting strength of the military itself. So there are not a lot of extra people out there in the service these days to deploy to deal with this pandemic. It really is going to depend on being able to call on people from across the country, as we did, changing our licensure rules to make sure people are able to work within our jurisdiction, taking I would say allied health professionals and giving them more responsibility. This goes from having pharmacists and others give vaccines when they're available, do other healthcare tasks to make sure that we can keep up with the demand. So I'm not sure the military is the answer for this. The military is great at lift and transporting ventilators and other supplies into areas where it's needed. But on the manpower side, I would say, unless it's control of sort of control of people. The military, I think, on the medical side would not be the place we shouldn't depend on military personnel in this kind of a thing.
Leo, can I add a comment to that?
Please do.
Robert Wood Johnson had the responsibility of leading the tent that was set up, the military camp that was set up in Edison. You know, we set up a 300-bed ambulatory military hospital there. But because of the limits of what they're able to do, they're really set up for mass, casualty, trauma events, et cetera, or crisis events. We actually found incredibly little use for that, unfortunately.
Oh.
I think at peak, while it had several hundred capacity, we had 20 patients there. And it was so, I'm glad that the federal government tried to help, but we actually had relatively little benefit from it.
But by the time you can get those things set up, the worst of the pandemic had happened. People had either died or they had, survived the disease and moved on to other levels of care. So I suppose if we had those things in place at the very beginning and could actually achieve getting them in place in the beginning, they might have had an impact. But by the time you could get the resources marshaled and then into New Jersey, into New York, the worst of it had already happened. So it's I can't say could the response have been more rapid? I suppose the federal government will have to look at its response, and that's obviously the subject of the current campaign. But I'm sure there's plenty of criticism to go and directed at all levels.
Thank you, Bert. Thank you, James. Host of questions. I think we have anxious medical students or anticipating medical students for Dr. Terragino. There have been several questions regarding their clinical experience and what concrete approaches we're going to implement in order to have a good clinical experience and education for them during the second wave. Cool. You're still muted. I'm sorry. Yes.
Doing our very best to make sure that we have at Rutgers stockpiled N95 masks, because we understand the challenges that the hospitals are having right now. So we've been doing multiple fit testing depending on the types of N95 masks that are available. So we're doing everything we can to keep our students on the wards. That's going to be one of my contingency plans. What is going to happen? But I think that I'm just going to share an example. There's a medical school in the South that has an OBGYN rotation. And Jocelyn, this is going to blow your mind. They do so much simulation, the students only spend 40 hours clinically to meet their graduation competencies. So every school is going to have to figure out what is it that a graduating student has to do. So we're thinking about those really important decisions. And to the student who wrote, I do think that these changes are going to carry over. My current third-year class is not going to finish up. There are many, many students that are going to be pushing third-year clerkships into the fourth year, which is going to impact the rising third-year students for next year. So it's going to take a couple of years. But again, if the PPE lasts, I think we're going to be okay. Because the other thought is we pulled our students, we didn't let them see patients that had COVID, but it wasn't because we don't think our students should take care of patients with COVID. Hopefully our students understand it's because we had to think about the risks about not having enough PPE and keeping people protected. So I think we're just going to be needing to reevaluate. If the PPE stays, we may not, and if the PPE stays and the stressors are not too much on the healthcare workers, we may not have to shut down clinical rotations.
Thank you, Carol. Question more for, I think, directed towards Jocelyn and our diversity dean, with respect to what actions what can we do to reach out to communities which have a mistrust of the vaccine. Any thoughts on that? For example, how would the state mandate school children receiving vaccines to return to public schools if there's not a mistrust?
It's a great idea.
Any thoughts? Yeah.
I think, the thing that has to be happening now while we're in the peri-COVID time frame is that those conversations need to be happening with community partners. So there's community leaders that are out there already. At Cooper, we have this med ed, organization where all of the health leaders and all of the educational institutions meet on a regular basis and have these discussions. And our community leaders are, quite frank in telling us when we're not doing things appropriately, when we're setting up, if we're setting up a COVID test site in the community, but they don't think it's in the area that it should be, they're very open about telling us those things. But I do think that we do have to worry about their concern about safety of the vaccine, just as many, of the panelists have even, said the concern about whether it's going to be an appropriate vaccine right now. I think people, if push comes to shove, there are going to be a lot of people who say, well, if you're mandating that my child gets vaccinated prior to going back to school, many of them are going to keep them home. So we may have to think about, is a state mandate or a national mandate in place, going to be in place for vaccination?
Great question.
Well, I would say, as far as COVID's concerned, I would just say I have no plans for a mandate along as regards a COVID vaccine. We are, along with state planning for the distribution of vaccine, but flu is another kettle of fish. I mean, we mandate flu vaccination for childcare, for pre-K, for hospital workers, for nursing home workers. And the reason why we have concerns about this current fall and winter season is that we know that while that children in particular drive the epidemiology of flu vaccine among the rest of the population. And so if we're not careful as we return to normalcy, more and more children enter school, that if we don't, my view, increase our vaccination rates, and principally among the principal drivers of flu vaccine, unlike COVID, flu is driven among the young and spreads to the rest of the population. So unless we, in my view, to protect the rest of the population, it is a common sense measure to increase those vaccination rates, and a mandate, in my view, is appropriate. We do that for all the childhood vaccines. And this year, at this time, with this possibility of a twin-demic of viral illnesses that can cause fever and other systemic effects that make it difficult to distinguish which one you have and which one you
Yeah, absolutely agree. Flu
it's
should be everybody.
Yep.
Wonderful. Thank you. Thank you for the discussion. Shifting gears a little bit, another question was with respect to the death rates. I think it was directed more to Dr. Sable. With the numbers rising, yet the death rates are low, which are much lower than the beginning. Why might this be? What are the factors contributing to this from a health systems perspective?
Yeah, I think the answer is we got smarter. We started without knowing really anything about this disease. We were intubating patients, putting them on a breathing machine pretty much immediately. If somebody came into the ER, I'm an ER physician, and we saw somebody with an oxygen saturation of 75%, we would freak out. We would quickly try to do something. As we started to see that most of the patients who were put on ventilators were dying, we rethought. We went back and saw what was working and what wasn't. We started to utilize high flow oxygen much more, and really utilized other modalities at our disposal, such as proning, which is putting patients on their stomach, laying down, to allow more air to penetrate the upper alveoli of the lungs. We just got smarter. We also learned about the hypercoagulable effects of the disease. And understood to watch for blood clots in the lungs and other places. And unfortunately, if you got COVID early on, your survival rate was probably lower than it is today, because we have finally some data and history to be able to improve our treatment plans.
Oh, thank you, Ken. Dr. Mazzarella, any thoughts?
Yeah, I think there's another factor too, that the recent rise now, I think is happening, at least what we're seeing is it's a younger population. So that younger population is going to have better outcomes. So as we track the cases that were coming in now, we see that it's a younger demographic. And so we would expect the death rate to be lower. So that could be that we not only, as Dr. Sable saying, we're getting smarter at how to treat it, but people are also getting smarter and that vulnerable populations are doing better protecting themselves. And so it's spreading in a different way. So rather than having it devastate the long-term care community, which it did in the first time around, now it's more spreading in the groups that are now more out there in a different way than before. So I think, you know, it's very easy at these lower numbers to say, oh, wow, it's a different virus, or why are people surviving more? No, it's probably the demographics are different right now. And so it's easy to get fooled by the demographics and just think because less people are converting into the ICU and less people dying, the disease is somehow different. But it probably, if you match demographically, it might not be.
There's also, we saw even earlier on that until the systems got overwhelmed, we were able to keep up with more of these patients. They did seem to do better. And as the systems got overwhelmed, the mortality rates went up. So as we're still dealing with modest numbers, thank goodness, you know, that may be part of just being able to keep up with this at this point.
Dr. Salwitz, leading to a second question from the audience. You had mentioned dual function hospitals during the presentation. And the question comes, since testing is inaccurate, and you have dual sets of patients, COVID people under investigation versus non-COVID. How does one expect to keep the COVID patients separate from the regular hospital patients when you don't have an accurate test?
But it's even slightly harder than that, because in many of the patients we're seeing now are arriving at the hospitals for other reasons. It's the car accident, I mean, that has a COVID, you know, it's the heart attack that has COVID. Actually, it's a large number of the patients that we're seeing. You know, our testing is a lot better than it was. You know, we are better at screening for symptoms. You know, I think early on, you know, we really had a 1/3, false negative rate. Those numbers are way down. We are actually better at that at screening. Plus, we're also better at routinely protecting our staff, so we have time to, move patients apart, et cetera. So I think, you know, it's more just having the concept that there are certain units we're going to keep as clean as possible, but we're going to continue to universally protect those as best as possible. We still require every patient in the hospital to wear a mask, even if they're sitting on bed recovering from foot surgery, to try to keep that rate down. And we've had a very low rate. I think most hospitals have in-hospital transmission. So it's actually more just how you distribute, I think, manpower and space, et cetera.
Thank you, Dr. Salwitz. For the panel as well, two relative questions and kind of general questions. With respect to telemedicine and reimbursement, some would argue the parity between telemed and in-person care. Do you think that's an accurate assessment, number one, and how to reimburse, what level of reimbursement, number two? So to Dr. Mazzarelli, thoughts?
Sure. So I'll tell you on Monday, Wednesday, and Friday, I would say there should be complete parity between the two, and that would be great. And that's how it should be, because it's more convenient for patients. It's a great tool for physicians to use, and that makes sense. But then on Tuesday and Thursday, I kind of say to myself, there's no way we can have that much more spending in the US health system, that a tool that would be that easy to use would just click up spending at a rate that would just be it's not practical that it would happen. So I think there has to be some kind of in between, and I don't think it's not as good. It's a useful tool in certain circumstances, but it's hard to say it has the same parity as touching patients and doing a full exam. So I think it'll have its place. And I think what that place is, we'll have to deal with reimbursement. I hope it's not the other way around, which often happens in the US healthcare system, where the reimbursement helps determine its place. I hope that's not what happens. I hope we find the right tool to use it, and that will help drive its reimbursement.
Dr. Sable, some thoughts? You're muted. You're muted again.
You're on mute.
For being the technology guy, you know.
I clicked the button. It's just I'm too fast. I clicked it twice. No, I totally agree with Dr. Mazzarelli. I mean, I think more and more telehealth is here to stay. It's not going away. I don't think the utilization is just going to, suddenly go through the roof and be unreasonable. There will be checks and balances on that, but reimbursement needs to, be appropriate for the level of service. I mean, we've in New Jersey had some success getting some of our payers to reimburse similar to a standard office visit. So, I think that for the better of patients, And let me just make a point just for a second about insurance companies, who I admire, of course. You know, throughout this whole pandemic, the insurance companies are collecting premiums. They're not paying out those premiums because patients aren't utilizing care. We have no revenues coming in because we stopped elective surgeries. We're spending a ton of money on PPE and agency labor and everything else. And the big winners at the end of the day are the big insurance companies. So, you know, I'd like to see them be held accountable to reinvest some of that money into the healthcare system as well.
I would agree.
Well, one way to do that with some efficiency is to pay the telemedicine visit on parity with the in-office visit, and then let consumers make a decision about what's best for them at the time that they need service. And so we're pushing that bill. We're going to continue on with that legislation. There is an argument that that there is, you know, a less cost in delivering that service, but technology has its costs, and there's a price to that as well. And so for all the things that you've mentioned about what's happening in the marketplace now, in the setting of the pandemic, and the future of healthcare, I think that if we decide for whatever reason not to pay for telemedicine on a parity basis, that we may find that there are not enough physicians there who are willing to practice. So when you say we have to get it right, we had better get it right, or we will suffer a loss of a physician workforce that'll be very detrimental to the country. So I'm for parity.
You know, I also just don't want people to forget about the need to address individuals where telehealth is, you know, not as easy as it is for the majority. And, you know, if we're going to pay all of this attention to it, it may further increase the health disparities that exist if we don't make sure that we're thinking about those marginalized populations.
Thank you. Carol, can we educate more telemed within our telehealth within our medical students?
Absolutely. There are 13 entrustable professional activities that are expected of medical students on their first day of residency, and there's a telehealth competency being added. And so we're all working in that direction, and we will certainly get them up to speed.
There's also a secondary societal saving in money. I did a telehealth consultation the other day of a patient for a blood question. I did not need to physically see the patient, examine them at all. He was a steel worker working at a site in Brooklyn. He lived in East Brunswick. He was at Brooklyn work. I did the consultation, perfectly good consultation, and he never had to leave the work site. He never had to come to the office. He never had to walk away. You know, those costs. He got his answered. I got my answered, and we moved forward. And there was significant money saved just by the time that how we took care of him.
The value of increased access to care, and by the way, as everybody on this panel very well knows, insurance companies are very good at not paying for care that's rendered, so they'll be just fine.
Hey, we have several questions from the audience regarding behavioral health and mental health during COVID. I'll throw it out to anyone who wishes to partake. I think there's an ample opportunity here because we've all been impacted by it. Dr. Sable, Dr. Salwitz, anyone?
I'll just say a few words. I mean, I think even before COVID, behavioral health, as we all know, has been a rising crisis in this country. The opioid epidemic, increased suicidal ideation, depression, anxiety has really plagued our society. This obviously made it worse. In addition to the patients that are suffering and the families, now people are fearing about economics and whether they're going to be out of work. If they're out of work, will they have healthcare insurance? And then on top of that, and we discussed the effects of the second victim syndrome almost, but physicians, we've seen physician suicide as a result of this as well. So there's really been nobody that's immune to this. And I think an already challenged and taxed healthcare system with regard to behavioral health only got worse. The one positive is I do think we have ramped up our efforts, certainly at Hackensack Meridian Health, and I've seen across New Jersey our telebehavioral health services. So we're increasing access to be able to provide services to people when they need it and where they need it and in a convenient way. So again, there's some positive there, but we're gonna need to invest a lot more money in behavioral health services over the next several years for sure.
And this is something that we're certainly seeing on our staff. We converted to video Schwartz rounds, which have been very helpful. We developed a peer-to-peer helpline for clinicians so they can reach out. But there's still a lot of clinicians in trouble. We have several clinicians that are now, out, on disability, as they try to get, heads together, and we have to be aware of these people. We have to be careful not to penalize these people for the stress and the problems that they're having, work them as peers, and support them. And know that a lot of them aren't going to reach out. You got to encourage our leadership to be saying to your people, how are you doing? How are your families doing? Are you getting the time for yourselves? This has to be deliberate, and and physician clinician wellness is already a problem, and it is significantly worse. And I worry about the PTSD effect if we go through this again. I would do it once because I ran to the battlements once, but do it twice because I think other people may not be doing the smartest things in the world. This may be really challenging for clinicians going forward. We have to be very conscious of this, or we could really lose people.
One of the things that in studying pandemics is that there is a delayed reaction. Unlike a hurricane or tornado, it comes, knocks everything down, you can start to rebuild. This is an ongoing presence, an ongoing threat. And what people who study this say is that you might see a delayed reaction to this that might come 6 months, I don't know when this thing is going to end, but might be very much delayed from when the crisis ends.
And there's some terrible stories. I have a nurse that infected both her parents, and both her parents died. How in the world do you cope with that over time? And there's some really bad things that have happened. We have to be very conscious of our people.
I want to take this opportunity to thank the panelists. We still literally have a dozen questions, but being respectful of everyone's time, I think that's a bit too much. I'd like to take this opportunity to thank our panelists, Dr. Conaway, Dr. Mazzarelli, Dr. Mitchell-Williams, Dr. Sable, Dr. Salwitz, Dr. Terragino for the time and expertise and addressing an important problem and facing healthcare. I learned something this evening. I think the insight was amazing, and I look forward to working through these problems together. On behalf of the Alumni Association, we're grateful to all of you for connecting with everyone virtually and joining us this evening. While we have different roles in different locations, what bonds us together is our shared history at Rutgers Robert Wood Johnson, and we look forward to seeing you at the next event. So again, my sincere thank you, and stay safe, and good night to all.
Nice to see everybody.
Thank you. Nice to see
Thank you.
everybody. Be safe. Bye-bye.
Bye-bye now.
Bye-bye now.